Welcome to the deep dive. Today we're jumping into three really vital, but maybe often overlooked, command centers in your body. We're talking about the thyroid, the parathyroid, and the adrenal glands. Now, our guide for this journey is a pretty hefty surgical textbook, so, dense stuff. But our mission here is to kind of distill all that complexity, pull out the really key bits of knowledge, those surprising facts, and give you a shortcut to understanding these crucial organs without feeling totally swamped. Think of it like a backstage pass to your body's regulation system. Okay, so let's unpack this. Maybe we can start with the history, because the history of thyroid surgery is actually pretty fascinating and, frankly, kind of brutal at the start. Yeah, get this. If you go way back to 1170, the first documented thyroid surgeries for goiters, those big neck swellings, were done by a surgeon named Roger Frugardi. And his method was, well, intense. He'd basically insert two threads, setons, right into the goiter at angles. Then he'd tighten them every single day until the tissue just stepped. And the wound, they treated it with caustic powder. So maybe not surprising. The mortality rates were just prohibitive, like over 40%. And it stayed that dangerous for centuries, well into the late 1800s.
Right. It really wasn't until the second half of the 19th century that things truly started to change. That's when we saw the arrival of three huge game changers in surgery: general anesthesia, proper antiseptic techniques to fight infection, and much, much better ways to control bleeding, what we call hemostasis. That allowed surgeons like Emil Theodor Kocher and Theodor Billroth, real pioneers, to finally tackle these surgeries with significantly lower death rates. They did thousands of operations, really refining the whole process.
And Kocher's work was so foundational, he actually won the Nobel Prize in Medicine for it in 1909. Which is incredible. But then here's where it gets really interesting. As surgery got safer and more people survived total thyroid removal, a completely new and unexpected problem popped up.
Exactly. They started seeing patients, especially children, develop this condition called myxedema. It's a severe form of hypothyroidism, basically the thyroid function plummeting. People were incredibly fatigued and kids had developmental delays. It was a direct, unforeseen consequence of the successful surgery.
So saving lives created a whole new puzzle.
Precisely. But that challenge spurred another massive breakthrough. In 1891, George Murray figured out the first effective treatment injecting patients with an extract from sheep's thyroids.
Wow, really? Sheep thyroids?
Yep. And then, just a few years later, Edward Fox showed that actually just taking the extract by mouth worked just as well. That discovery really laid the foundation for all the hormone replacement therapy we use today. It completely changed lives.
Okay, so let's shift gears a bit and talk about the thyroid gland itself. How it actually forms is, well, it's a bit unusual, right?
It really is. It starts super early, around the third week of pregnancy, as this tiny little outpouching from the primitive gut, way up near where the tongue develops. Its starting point is right at the base of the tongue, a spot called the foramen cecum. And then it actually travels, it descends down through the neck to its final position. Quite a journey.
And doesn't that journey sometimes leave something behind?
It can, yes. During that descent, it's connected to its origin by a temporary tube, the thyroglossal duct. Usually this duct disappears completely, but if it doesn't...
You get those cysts.
Exactly. Thyroglossal duct cysts. They're actually the most common congenital lump we see in the neck. About 80% of them are found near the hyoid bone, that sort of horseshoe-shaped bone in your neck. They're usually harmless, just sitting there, but they can get infected. And the treatment is a specific operation called the cyst-trunk operation. It's designed to remove the cyst and a part of the hyoid bone to make sure the whole duct tract is gone so it doesn't come back.
Interesting. And the thyroid itself has different kinds of cells doing different jobs.
Right. You've got the main workhorses, the follicular cells making the thyroid hormones T4 and T3. And then there are the parafollicular cells, or C cells, which make calcitonin. And they actually come from a different place embryologically.
So different origins, different roles, all in one small gland.
Pretty much. Now let's talk iodine, because without it, none of this works. Your thyroid is incredibly good at grabbing and storing iodine. Like over 90% of your body's total iodine lives right there. And this iodine is the absolute essential building block for making those thyroid hormones, T4 and T3. And you actually need a surprisingly tiny amount, only about 0.1 milligrams a day.
0.1 milligrams, that's it.
That's it. And you usually get it easily from foods like fish, milk, eggs, or things like iodized salt or bread.
Okay, so the thyroid grabs the iodine, makes the hormones. How does it know how much to make? What's the control system?
That's the hypothalamic pituitary thyroid axis. It sounds complicated, but think of it like your home thermostat.
Oh.
Your brain, the hypothalamus, sends a signal, TRH, to your pituitary gland. The pituitary then releases TSH, thyroid-stimulating hormone. TSH is the message that tells your thyroid, okay, make more T4 and T3. And when the levels of T4 and T3 in your blood are just right, that signal feeds back and tells the brain and pituitary to ease up on the TSH. It's a constant balancing act.
A feedback loop. And these hormones, T4 and T3, they do a lot, right? It's not just one thing.
Oh, absolutely. They set your basal metabolic rate, basically, how fast your body burns calories at rest. They influence your heart rate, how strongly your muscles contract, how you metabolize glucose and cholesterol. I mean, they touch almost everything.
So what this really means for you, the listener, is that even small changes in your thyroid function can have a huge impact on your energy, your weight, your mood, pretty much your whole system.
Definitely. It's a small gland with a massive job.
So what happens when that thermostat goes haywire and the thyroid starts working too hard? That's hyperthyroidism.
Exactly, hyperthyroidism. And the most common reason for it, at least here in North America, is Graves' disease. It accounts for like 60 to 80% of cases.
Graves' disease, that's autoimmune.
Correct. Your immune system gets confused and creates antibodies that actually stimulate the thyroid to just keep producing hormones, overriding that normal feedback loop. It tends to run in families, and it's much more common in women, about a 5-to-1 ratio, usually hitting between ages 40 and 60.
And what does that feel like for someone if their thyroid is in overdrive?
Well, imagine feeling constantly revved up. People often can't tolerate heat, they sweat a lot more, they might lose weight, even though they're eating plenty, their heart races or pounds palpitations, they feel anxious, nervous, shaky.
Sounds exhausting.
It is. And their emotions can be all over the place too, what we call emotional lability. But Graves' specifically has some other really characteristic features that aren't just about the thyroid itself.
Oh, like what?
The most well-known is the ophthalmopathy, the eye changes. About half of Graves' patients get this. Their eyes can bulge forward, that's called proptosis, and you might notice their eyelids seem to retract or lag when they look down, giving them this kind of staring look.
Wow, that sounds quite noticeable.
It can be, yes, and less common, maybe only 1 or 2% of patients, is something called pretibial myxedema. It's this odd, thickened, sort of waxy-looking skin, usually over the shins, very distinctive when you see it.
Okay, so if someone has those symptoms, how do doctors confirm it's hyperthyroidism and specifically Graves'?
Diagnosis usually starts with blood tests. We look for a TSH level that's really low or suppressed because the brain is trying to tell the thyroid to slow down, but it's not listening. And at the same time, the actual thyroid hormone levels, free T4 or free T3, are high. And then, to confirm it's Graves', we can test for those specific antibodies, the thyroid-stimulating immunoglobulins, or TSIs. If those are elevated, that pretty much seals the diagnosis of Graves' disease.
Right, so once it's diagnosed, what are the treatment options?
There are basically 3 main approaches. First, there are anti-thyroid drugs medications like propylthiouracil, or PTU, and methimazole. These work by interfering with a thyroid's ability to make hormones. PTU is often the go-to during pregnancy or breastfeeding because it crosses the placenta less readily than methimazole.
Okay, drugs are one option. What else?
Another very common treatment, especially in North America, is radioactive iodine therapy using a specific type, iodine-131. The thyroid naturally sucks up iodine, so it takes up this radioactive version, which then destroys the overactive thyroid cells.
So it kind of selectively targets the thyroid.
Exactly. It avoids surgery. It's generally less expensive. But it does have some potential downsides. It can sometimes make the Graves' eye problems temporarily worse, and some studies have suggested a possible small increase in long-term cardiovascular mortality, although that's still debated.
Okay. So drugs, radioactive iodine. What's the third option?
Surgery. Removing all or most of the thyroid gland, a thyroidectomy. This is usually reserved for specific situations, like if there's a suspicion of cancer alongside the Graves', if the patient is quite young, if they have a very large goiter that's causing compression symptoms, or if they have bad reactions to the medications.
Got it. So several ways to tackle an overactive thyroid. Now let's flip the coin. What about hypothyroidism when the gland is underactive?
Right, hypothyroidism. This is when the thyroid isn't producing enough hormone, and it's absolutely critical to catch this in newborns. If it's missed, it leads to a condition called cretinism, causing really severe developmental problems like intellectual disability.
Oh, wow.
That's why newborn screening for thyroid function is standard practice pretty much everywhere now. Immediate treatment makes all the difference for those kids.
That's huge. What about in adults? What are the signs of a sluggish thyroid?
In adults, the symptoms can be kind of vague and creep up slowly, which is why it sometimes gets missed. People often feel really tired, lethargic. They might gain weight even without changing habits, feel cold all the time, get constipated.
Kind of generic symptoms almost.
They can be, but there are also more specific signs doctors look for, like a characteristic puffiness in the face, especially around the eyes. The skin can become dry, maybe a bit yellowish. Hair can get brittle and coarse, and sometimes people notice thinning of the outer part of their eyebrows. That's quite a classic sign.
Huh, the eyebrows.
Hmm.
Interesting. What's usually causing hypothyroidism in adults?
By far the most common cause is Hashimoto's thyroiditis. Like Graves', it's an autoimmune disease. But here, the immune system attacks and gradually destroys the thyroid gland tissue rather than stimulating it.
So another case of friendly fire from the immune system.
Exactly. And again, it predominantly affects women, usually between the ages of 30 and 50. Often the thyroid gland feels enlarged and kind of firm or rubbery.
And is there anything else associated with Hashimoto's?
There's a rare but important link to thyroid lymphoma, a type of cancer. It's not common, but it's something doctors keep in mind. Mostly, though, the treatment for Hashimoto's and hypothyroidism generally is straightforward. Replacing the missing hormone with synthetic T4 medication, usually levothyroxine.
Okay, so hormone replacement. Makes sense. Now, let's talk about lumps and bumps, thyroid nodules, and the possibility of cancer. You mentioned goiter earlier.
Right, so a goiter just means any enlarged thyroid. Often it's the thyroid trying to compensate when it's not making enough hormone, so TSH stimulates it to grow. Historically, in places without enough iodine in the diet, huge goiters were common endemic goiters. Thankfully, iodized salt pretty much fixed that in places like North America.
So people still get smaller lumps, right? Nodules.
Oh, yes. Solitary thyroid nodules are actually really common. Maybe 4% of adults in the U.S. have one you can feel, and many more show up on ultrasounds done for other reasons.
4%. That sounds like a lot. But thyroid cancer isn't that common, is it?
That's the crucial point. Nodules are common, but cancer is rare. We see maybe 40 new cases of thyroid cancer per million people each year. So the big challenge is figuring out which of those common nodules might actually be one of the rarer cancers. Risk assessment is key.
Okay, so this raises the big question. What puts someone at higher risk? What are the red flags for thyroid cancer in a nodule?
There are a few important ones. A major one is a history of exposure to ionizing radiation, especially as a child or adolescent. We learned this the hard way from historical low-dose radiation treatments for things like acne or enlarged thymus glands decades ago.
Right, things they don't do anymore.
Absolutely not. And also from nuclear fallout events like Chernobyl in 1986. That exposure significantly bumps up the risk of papillary thyroid cancer, the most common type, and it's often linked to specific genetic changes like RETPTC rearrangements.
So radiation's a big one. What else?
Family history is definitely another. If you have close relatives with medullary thyroid cancer or certain types of familial non-medullary thyroid cancer, your risk is higher. These inherited forms often show up as multiple tumors.
Okay, so radiation exposure and family history are key risk factors. If someone have a nodule, how do doctors investigate it?
The main tool is a fine needle aspiration biopsy, or FNA. It sounds a bit scary, but it's usually a quick outpatient procedure. We use a very thin needle, often guided by ultrasound to be precise, to suck out a small sample of cells from the nodule.
And those cells go to the lab.
Exactly. A pathologist looks at them under the microscope to see if they look benign, malignant, or somewhere in between suspicious or indeterminate.
What happens if it's indeterminate, if they can't tell for sure?
That's where things have really advanced recently. We now have sophisticated molecular tests, things like Thyroseq or panels looking at microRNAs. These tests analyze the genetic material within the nodule cells for specific mutations or patterns known to be associated with cancer. They can really help clarify the situation, help rule in or rule out malignancy with a much better confidence, which helps decide if surgery is really necessary or if we can just watch the nodule.
That's a big step forward, avoiding unnecessary surgery. So if it is cancer, what are the main types we're talking about?
There are 4 main types, but one is much more common than the others. Papillary thyroid carcinoma, PTC, accounts for about 85% of all thyroid cancers. It's often linked to those radiation exposures we mentioned and specific mutations like BRAF V600E, which can sometimes mean it's a bit more aggressive, or those RET-PTC rearrangements.
Okay, 85% papillary. What's next?
Next is follicular thyroid carcinoma, FTC, making up around 10%. This one can be tricky because the FNA often looks similar to a benign follicular nodule. The definitive diagnosis requires looking at the surgically removed tissue to see if the cancer cells have invaded the capsule around the nodule or into blood vessels.
So you need the surgery to be sure sometimes.
Often, yes. Then there's medullary thyroid carcinoma, MTC. This arises from those C cells we talked about earlier, the ones that make calcitonin. It's less common, maybe 3–4% of cases. What's really notable about MTC is that about 25% of cases are hereditary, linked to inherited mutations in the RET gene. This can be part of syndromes like MEN2. If we find someone has that mutation, we might even recommend removing the thyroid proactively to prevent the cancer from ever developing.
Wow, preventative thyroid removal based on genetics.
It's becoming more common for specific high-risk mutations. And finally, there's anaplastic carcinoma. Thankfully, this is very rare, maybe 1% of cases, but it's extremely aggressive. It usually presents as a rapidly growing neck mass and, unfortunately, has a very poor prognosis.
So a range from very common and often treatable to rare and very aggressive. How is thyroid cancer generally treated?
Surgery is almost always the first step. For most cancers over a centimeter, the recommendation is usually to remove the entire thyroid, or nearly all of it, a total or near total thyroidectomy. Sometimes for very small, low-risk microcarcinomas, just removing the half of the thyroid containing the tumor, a lobectomy, might be sufficient. After surgery, for differentiated cancers like papillary and follicular, radioactive iodine therapy, that same iodine-131 we use for hyperthyroidism, is often given. Here, the goal is to ablate or destroy any tiny remnants of thyroid tissue left behind, including potential microscopic cancer cells, and it also helps us detect if the cancer has spread.
So surgery first, then often radioactive iodine. Any other treatment?
For more advanced situations, like cancer that can't be removed surgically or has spread widely, external beam radiation therapy might be used. And more recently, for advanced progressive cancers that aren't responding to other treatments, we're starting to use targeted molecular therapies drugs called multikinase inhibitors that target specific pathways involved in the cancer's growth. Their role is still evolving, but it's a growing area.
Okay, it's a lot on the thyroid. Let's pivot now to the parathyroids. Often confused with the thyroid, but totally different job, right?
Totally different. Same neighborhood in the neck, often right behind or even embedded in the thyroid, but their function is completely separate. They are the body's chief regulators of calcium. That's their main gig.
Calcium control central.
Pretty much. And their development is interesting too. The upper pair comes from one embryonic area, the lower pair from another, along with the thymus gland. That shared journey with the thymus is why the lower parathyroids can sometimes end up in weird places, like down in the chest. Their anatomy can be quite variable.
So they manage calcium. How do they do that?
Through parathyroid hormone, PTH. When your blood calcium level dips even slightly, the parathyroid glands sense it and release PTH. PTH then acts in three main ways. It tells your bones to release a bit of calcium into the blood. It tells your kidneys to reabsorb more calcium instead of letting it go out in the urine. And it indirectly helps your intestines absorb more calcium from your diet by activating vitamin D. All designed to bring that blood calcium level right back up into the normal range.
It's a very precise system. What about that other hormone, calcitonin, from the thyroid C cells? Doesn't that affect calcium?
It does. Technically, it lowers calcium, but in humans, its actual physiological effect on day-to-day calcium balance seems pretty minimal. Its main clinical use is as a very sensitive tumor marker for medullary thyroid cancer, which arises from those C cells.
Got it. So PTH is the star player for calcium. What happens if the parathyroids make too much PTH?
That leads to primary hyperparathyroidism, or PHPT. It's actually a fairly common endocrine disorder, and historically it was known for causing a classic set of symptoms, sometimes remembered by the rhyme: kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones.
Catchy, but sounds unpleasant.
Very. But here's the thing nowadays, because routine blood tests often pick up high calcium levels much earlier, most patients are diagnosed when they have minimal or even no obvious symptoms. The classic pentad is much less common now.
But even if people don't feel sick, can the high calcium still cause problems long term?
Absolutely, that's the key point. Even mildly elevated calcium over years can take a toll. Kidney stones are still pretty common, maybe affecting 20–25% of patients. Bone health suffers. People develop osteopenia or osteoporosis. increasing fracture risk. In severe, long-standing cases, you can see that bone condition called osteitis fibrosis cystica, where bone gets resorbed. There can also be gastrointestinal issues like peptic ulcers, pancreatitis, maybe gallstones. And the psychic moans part is real, too. Patients can experience depression, anxiety, memory problems, fatigue, and in very severe hypercalcemia, confusion, or even coma. It's fascinating, really, how widespread the effects of calcium dysregulation are.
So diagnosis is based on blood tests showing high calcium and high PTH.
Yes, elevated serum calcium along with an inappropriately high or normal intact PTH level confirms the diagnosis. It's important to note that imaging studies like a sestamibi scan, ultrasound, or maybe a specialized 4D CT are usually done before surgery, but they're not for diagnosis. They're localization studies.
Like a treasure map for the surgeon.
Exactly. To help the surgeon figure out which of the four, usually four, tiny parathyroid glands is the culprit causing the problem, making the surgery potentially quicker and more focused.
And is surgery the main treatment?
It's the only curative treatment for primary hyperparathyroidism, and it's a very effective surgery called parathyroidectomy, has success rates over 95%. It normalizes the calcium and PTH levels, resolves symptoms, and leads to improvements in bone density.
So even if someone feels okay, surgery might still be recommended.
Yes, there are clear guidelines for that. Even in asymptomatic patients, surgery is generally recommended if their calcium level is significantly elevated, if their kidney function is starting to decline, if they have kidney stones, if their bone density is substantially reduced, like osteoporosis, or if they're relatively young, typically under age 50.
What happens if the first surgery doesn't work, or the problem comes back later?
That's called persistent or recurrent hyperparathyroidism. It often means either an abnormal gland was missed initially, maybe it was in an unusual ectopic location, or the person actually had hyperplasia, meaning all four glands were enlarged and not enough tissue was removed. These reoperative cases are more challenging, and that's where intraoperative PTH monitoring becomes absolutely critical. We measure the PTH level in the patient's blood during the surgery. A rapid drop after removing a gland confirms we got the culprit tissue. If it doesn't drop, the surgeon knows they need to keep looking.
Real-time feedback in the OR. Clever. Are there other, rarer parathyroid problems?
Briefly, yes. Parathyroid carcinoma is very rare, maybe less than 1% of cases. It usually presents with much higher calcium and PTH levels, and often the tumor can be felt in the neck. It tends to be more invasive. And then there's hypercalcemic crisis. This is a true medical emergency where calcium levels are dangerously high, causing acute symptoms. Patients need urgent medical treatment to lower the calcium before they can even be considered for surgery.
Okay. Now, what about the opposite problem? Too little PTH causing low calcium. Hypoparathyroidism.
Right, hypoparathyroidism. And the most common cause for this today, by far, is actually previous neck surgery, particularly total thyroidectomy, especially if it involved removing lymph nodes in the central neck compartment.
So it's a complication of thyroid surgery.
It can be. Those tiny parathyroid glands are delicate and sit right near the thyroid. Their blood supply can be easily disrupted, or they might be accidentally injured or removed during a complex thyroid operation, leading to low PTH and consequently low calcium.
What does low calcium feel like?
The symptoms are primarily neuromuscular. People often first notice tingling or numbness, especially around the lips and in the fingertips. They might feel anxious or irritable. Doctors look for specific signs. SCHWARTZ sign, where tapping the facial nerve causes facial muscles to twitch.
Oh.
And Trousseau's sign, where inflating a blood pressure cuff on the arm for a few minutes causes a characteristic spasm of the hand and wrist called carpopedal spasm. Treatment involves taking oral calcium and activated vitamin D supplements to keep the blood calcium levels stable.
All right, we've covered thyroid and parathyroid. Let's tackle the third set, the adrenal glands, the stress and balance powerhouses.
That's a good way to put it. These two little glands sit like hats on top of your kidneys, and they're really fascinating because each one is essentially like two distinct organs fused together. You have the outer layer, the adrenal cortex, and the inner core, the adrenal medulla.
Two organs in one, and they make different hormones.
Completely different sets. The outer cortex makes three main classes. Mineralocorticoids, with aldosterone being the key one. It manages your sodium and potassium balance, which is critical for blood pressure control. Then glucocorticoids, mainly cortisol, your primary stress hormone, but it's also involved in metabolism, immune function, inflammation, tons of things. And lastly, the cortex makes small amounts of sex steroids, mostly androgens.
Okay, cortex, aldosterone, cortisol, sex steroids. What about the inner medulla?
The medulla is all about rapid response. It produces catecholamines, think epinephrine, adrenaline, norepinephrine, noradrenaline, and a bit of dopamine. These are your classic fight or flight hormones kicking in during stress or excitement.
Got it. So let's talk about when things go wrong with these hormones, starting with too much from the cortex, like too much aldosterone.
Right, that's hyperaldosteronism, often called Conn's syndrome. It's caused by the adrenal gland making too much aldosterone on its own, independent of the normal controls. The main results are high blood pressure, which can be hard to treat, and often low potassium levels in the blood. In about 70% of cases, it's caused by a single small tumor in the cortex, an adenoma, that's just churning out aldosterone.
How do you pinpoint that?
Imaging like CT or MRI scans can often spot the adenoma, but sometimes the scans look normal, or maybe both glands look a bit enlarged. In those cases, a specialized test called adrenal vein sampling, or AVS, is really the gold standard.
Adrenal vein sampling.
Yeah, it's an interventional radiology procedure where they thread tiny catheters into the veins, draining each adrenal gland, and measure the aldosterone levels directly. It's very precise in figuring out if the excess aldosterone is coming from one side or both. If it's clearly unilateral from one tumor, then surgically removing that adrenal gland, adrenalectomy, is the cure.
Okay, that's aldosterone. What about too much cortisol? That's Cushing syndrome.
Correct. Cushing syndrome is the state of having excessive cortisol from any cause. And it produces some really striking, classic physical changes over time.
Like what? I've heard of moon face.
Exactly. Progressive obesity, particularly around the trunk with thinner arms and legs, the moon facies where the face becomes very round and full, a fatty deposit on the upper back, often called a buffalo hump, thin skin that bruises easily, and sometimes prominent purplish stretch marks or striae, especially on the abdomen. Women might also develop excess facial hair or hirsutism.
Wow, quite a collection of signs. So what does this mean for the body overall? How does all that extra cortisol impact things?
It really impacts almost every system. High blood pressure, high blood sugar or diabetes, weak bones, osteoporosis, muscle weakness, increased risk of infections, mood changes like depression or anxiety, sleep disturbances. The list goes on. It's a serious systemic illness.
So how do you diagnose Cushing's and figure out where the extra cortisol is coming from?
First, you have to confirm that there actually is too much cortisol being produced. We use tests like the overnight low-dose dexamethasone suppression test, basically, giving a small dose of steroid medication at night and seeing if it properly suppresses the body's own cortisol production the next morning. Or we measure the amount of free cortisol excreted in the urine over a full 24 hours. Or check cortisol levels in saliva late at night when they should normally be very low. Once we've confirmed Cushing's syndrome, the next step is figuring out the source. Is it a tumor in the pituitary gland making too much ACTH signal? That's called Cushing's disease. Is it a tumor in the adrenal gland itself making cortisol directly? Or rarely, is it a tumor somewhere else in the body ectopically producing ACTH? Different tests, including measuring ACTH levels and sometimes more imaging or specialized sampling, help sort that out.
And the treatment depends on the source.
Absolutely. If it's a pituitary adenoma, the treatment is usually surgery to remove that tumor, often through the nose transsphenoidal surgery. If it's an adrenal adenoma causing it, then laparoscopic removal of that adrenal gland is the way to go. One really critical point with adrenal surgery for Cushing's is managing steroids. Because the tumor has been overproducing cortisol, the other, normal adrenal gland, often becomes suppressed and dormant. So patients need steroid coverage during and after surgery, which is then slowly tapered off over weeks or months as their remaining gland wakes back up.
Ah, okay, that makes sense. Now, adrenal medulla tumors. Pheochromocytomas, these sound dramatic. You mentioned the 10% tumor rule.
Yeah, it's a classic mnemonic, though the numbers aren't exact science. It helps remember key features. Roughly 10% are bilateral in both adrenals. 10% are malignant, 10% occur in kids, 10% are extra adrenals, meaning they arise outside the adrenal gland, often called paragangliomas. And maybe more than 10% now, actually, are familial or hereditary.
So what exactly are they and what do they do?
They are tumors arising from the chromaffin cells of the adrenal medulla, or similar cells in sympathetic ganglia along the spine, and they secrete excessive amounts of catecholamines, epinephrine, and norepinephrine.
Those fight or flight hormones. So what happens when you have way too much?
It causes classic episodes, or sometimes sustained symptoms, often described by a triad: severe headache, heart palpitations, and profuse sweating, diaphoresis. This is often accompanied by episodes of very high blood pressure or sometimes sustained hypertension. It can be quite dramatic and frightening for the patient.
And you said they can be inherited.
Yes, there's a strong genetic component for a significant portion of pheochromocytomas and paragangliomas. They're linked to several inherited syndromes, most notably multiple endocrine neoplasia type 2, MEN2, caused by RET gene mutations, but also von Hippel-Lindau disease, VHL gene, and neurofibromatosis type 1, NF1 gene, among others. Genetic testing is often recommended.
Okay, so if someone is diagnosed with a pheo, what's the treatment? I imagine surgery is tricky if the tumor is full of adrenaline.
Extremely tricky, and that's why the preoperative preparation is absolutely crucial. Before a patient with a pheochromocytoma goes to surgery, they must undergo careful medical blockade.
Blockade.
Yes, typically starting with alpha blockers, drugs like phenoxybenzamine, for usually 1 to 3 weeks before surgery. This helps control the blood pressure and prevents the massive surges that could happen when the surgeon handles the tumor. After adequate alpha blockade, beta blockers might be added if the heart rate is still high. Patients also need to make sure they're well hydrated, restoring blood volume. This whole process is vital to make the surgery safe.
That sounds like really critical prep work.
It absolutely is. Once the patient is properly blocked, the treatment is surgical removal of the tumor, adrenalectomy. This is often done laparoscopically, especially for smaller tumors. But the anesthesia and surgical teams have to be incredibly vigilant throughout the case, managing potential blood pressure swings. For the hereditary forms, which are more likely to be multiple or bilateral, sometimes surgeons will perform a cortical-sparing adrenalectomy, removing the pheochromocytoma, but trying to leave behind some of the normal adrenal cortex to avoid lifelong steroid dependence, if possible.
Fascinating complexities. Okay, one last adrenal topic. The incidentaloma. What's that about?
An adrenal incidentaloma is exactly what it sounds like, an adrenal mass or lesion that's discovered incidentally, meaning by accident, on an imaging scan like a CT or MRI that was done for some completely unrelated reason. Someone gets scanned for back pain or abdominal pain, and voila, there's a lump on the adrenal gland.
And this happens often.
Increasingly often with the widespread use of high-resolution imaging. The good news is that the vast majority of these are benign, non-functioning cortical adenomas, just harmless little lumps.
But not always.
Not always. A small percentage, maybe around 8% or so, might represent what we call subclinical Cushing syndrome. They're producing a little bit too much cortisol, but not enough to cause the obvious full-blown Cushing symptoms. Still, that subtle excess cortisol can potentially have long-term health consequences, like worsening diabetes or hypertension. And less commonly, an incidentaloma could be a pheochromocytoma, an aldosterone-producing adenoma, or even rarely a malignancy, either primary adrenal cancer or a metastasis from cancer elsewhere. The risk of malignancy generally increases with the size of the lesion. For example, lesions over 6 centimeters have a much higher chance, maybe 25%, of being cancerous.
So if one of these is found by chance, how do you figure out what it is and what to do?
It requires a careful workup. First, hormonal screening tests are essential to see if the tumor is producing any excess hormones, typically tests for cortisol excess, like the dexamethasone suppression test, catecholamines metanephrines for pheochromocytoma, and sometimes aldosteronerin if the patient has hypertension. Second, we look closely at the imaging characteristics. How big is it? Does it look uniform or irregular? Does it have fatty tissue in it, which suggests benign? How does it look on special CT sequences, measuring Hounsfield units? These features help assess the likelihood of malignancy.
And then, based on all that,
the management depends on the findings. If the incidentaloma is hormonally active, functioning, it generally should be removed surgically. If it has suspicious imaging features suggesting malignancy, or if it's quite large, say over 4 to 6 centimeters, though thresholds vary, surgery is also usually recommended. But for the majority that are small, non-functioning, and have benign imaging features, we can often manage them conservatively with periodic follow-up, maybe repeat hormone testing and imaging after 6-12 months, and then less frequently to make sure they're not growing or starting to produce hormones.
So a lot of watchful waiting for the harmless ones.
Exactly. Avoids unnecessary surgery.
This whole discussion covering the thyroid, parathyroids, adrenals, it really drives home how specialized this area of surgery is. It's not just cutting. It's about understanding these intricate hormone systems.
Absolutely. Endocrine surgery is very much about meticulous technique and understanding the physiology. For instance, In the neck, we often use that cocher transverse collar incision you mentioned, placed carefully in a skin crease for a good cosmetic result. But the real work is underneath the painstaking dissection needed to identify and preserve crucial structures. We talked about the recurrent laryngeal nerve controlling the voice and those tiny parathyroid glands essential for calcium balance. Protecting those is paramount. And we're also seeing more minimally invasive approaches, endoscopic or robotic surgery for thyroid and parathyroid, for example. These can offer cosmetic advantages, though they might take longer or cost more sometimes.
Right, and that brings up a critical question. How do surgeons actively try to minimize those risks we talked about, like nerve injury causing voice changes, or damaging the parathyroids and causing low calcium? What specific things are done during the operation?
Well, first and foremost is surgeon experience. High-volume endocrine surgeons generally have lower complication rates, but beyond that, we use specific techniques and adjuncts. Careful identification of the recurrent laryngeal nerve is key, sometimes aided by intraoperative nerve monitoring devices. For the parathyroids, it's about gentle handling, preserving their delicate blood supply, and sometimes even auto-transplanting a gland, moving it to a muscle pocket if its viability seems compromised. And as we discussed for hyperparathyroidism, that intraoperative PTH monitoring is a fantastic tool to confirm we've removed all the bad tissue while leaving the good glands intact. It really combines surgical skill with real-time biochemical feedback.
It sounds like a field where precision is absolutely everything.
It truly is. Millimeters matter.
Looking back at everything we've covered, it's just incredible, isn't it? These relatively tiny glands scattered in the neck and abdomen, orchestrating such fundamental aspects of our health through hormones. And the journey from those, frankly, terrifying medieval procedures to today's incredibly precise, genetically informed surgeries and treatments, it's just a world of difference.
Yeah, it really is revolutionary. And if we connect this to the bigger picture, the advances are only accelerating. Our understanding of the molecular genetics behind these conditions, identifying specific driver mutations, oncobody genes, tumor suppressor genes, is exploding. This knowledge isn't just academic, it's directly refining how we diagnose these conditions, predict their behavior, and develop even more personalized, targeted therapies. We're moving beyond just surgery and general medications into an era of truly precision endocrine medicine.
So maybe a final thought for everyone listening as you go about your day, just take a moment to consider these small but mighty glands, how their intricate hormonal signals, their surprising developmental journeys, and even their genetic predispositions highlight the incredible complexity and interconnectedness of the human body. It makes you wonder, what new secrets are these tiny powerhouses still holding? And how will unlocking them continue to change medicine and our health in the future? Thank you so much for joining us on this deep dive. Until next time, keep exploring, keep asking questions, and stay informed.